Today we have a very nice topic about knowledge translation in burden of disease studies. So it goes a bit, it differs a bit from the previous webinars, since this one is less methodological and scientific, but more about like the people that actually use what we develop in burden of disease studies. So today I want to welcome 3 speakers. So today's webinar is going to be a bit longer than normally, but it's totally worth it. So stay with us. So today we have two Alines, not one, but two. One from Aline Anton from Robert Koch Institute in Germany, and Aline Skoy from Cienzano in Belgium. And then we have Henk Hildering from RIVM in the Netherlands that was actually leading the working group on knowledge translation in the Burden EU network. And as you all may know, these webinars are organized by the Burden EU network, which is a technical platform that would like to integrate and strengthen capacity regarding burden of disease assessment across Europe and beyond. And this network has been going on since 2019, and it's still quite active. And apart from this webinar, that like with all these webinars that happen more or less once every 2 months, which is a good way to connect to each other and learning about each other's work. We also have other activities. And one among all is the summer schools that we organize every year. So this summer as well, we will be having the summer schools based in Ghent. You see the pictures from the last edition there. And we have 3 summer schools, one on general concept of burden of disease, one on the burden of risk factors, and the last one on infectious diseases. And if you're interested in one of these summer schools, please contact us as soon as possible, because there are a few places left. But without further ado, I'll give the word to Aline Anton that will give us a bit of an introduction about what is knowledge translation and why it's important. And then she will introduce us to her work that she did with stakeholders in Australia, where she interviewed them and like had a bit of a view of how they use burden of disease. So Aline, please, the floor is yours.
Thank you very much. So I will share my screen. And please let me know if you see the presentation.
Yes, we do. Thank you very much.
Okay. So I would like to talk about the role of knowledge translation in burden of disease studies. And 1 second. So the presentation starts. Now. So yeah, I will talk about knowledge translation as an introduction and then present the results of a project that I did last year in Australia for a couple of months called the reception of health data using the Australian burden of disease study as an example. And I have a very few slides from next steps for the German burden of disease study. So the knowledge translation concept is in general the effective and timely incorporation of evidence-based information into the practice of healthcare professionals to achieve optimal healthcare outcomes. So it was originally invented to incorporate or develop for healthcare professionals and optimal healthcare outcomes, but we can adapt it to burden of disease. And knowledge translation activities bring research and scientific findings into the hands of decision makers, people and organizations who can put them to practical use. So knowledge translation means impact, and I've put a question mark behind it, and we'll come back to this slide at the end of the presentation. So we have a couple of recurring problems with burden of disease. One is the general knowledge. Second is the understanding of the concepts. We have to explain the meaning of burden of disease. and we have to make this information available for political or other decision makers, our stakeholders. And our aim is to bridge the gap between researchers, between what we do and our users and stakeholders. And I have a quote from one of the interviews that I did and that I put here. It's one thing to have a set of numbers. It's another thing to just let people know what those numbers mean. And I think that sums it up pretty well. Our baseline, let's call it problem, is, or that's a kind of setting. As a researcher, or people working at the public health institutes, we produce data and evidence in form of valuable indicators. And first thing we often do is to produce a scientific paper, because that is our currency. That is our basic product and outcome. If you're a user who needs data and evidence and who has not much time, and she gets offered a paper, a scientific paper, that is not the best option to translate or to give this information. So scientific evidence is just one of many sources that influence the political process. The political arena has many powerful players, and there is an enormous number of political problems that could be at the top of a political agenda. So just offering scientific papers is not the best option to give information. So if a user needs data and evidence, if we invest in knowledge translation, we can make these users a little bit more happy. And when preparing a communication strategy, I think there are some key questions that we should ask ourselves. Which of the results are particularly suitable or useful, and why? How can we explain burden of disease indicators and results to our target groups? And we have to think of which tools we can use that are available for us at the public health institutes, what kind of products we want to have as output, who is our audience, and do we have sufficient capacity and funding, which is one of the keys to do all this, and do we have a platform to spread information and create everything around. So the key needs for me, or that I think we need, is a platform, like a website we can use and build everything around. We need a network of users and stakeholders. We need tools and products, and we need capacity in form of researchers, funding, IT resources, and things like that. So the start for an effective knowledge translation strategy is to have a bit of knowledge on theory and background. What does knowledge translation mean, or what does it contain? We have to organize the interactions. So we have to build this actor network, and we need to present our product. So we need to know what do we want to produce actually. And whoever has heard one of Hank's presentations knows this model. It's based on the Canadian Institute of Health Research. We have this push-pull, exchange, integrate modeling of knowledge translation. So a push situation means research findings will be passed on to policymakers by making them more accessible and easier to use, for example, by preparation of user-friendly summaries or things like that. In a pull situation, efforts concentrate on how policymakers are supported and demand evidence from the research community, for example, by providing systematic reviews or things like that. And the problem here is that it bit oversimplifies the real world uptake, and power and timing and context can be neglected. So in exchange efforts, encourage research and policymakers to develop partnerships and collaborative projects or shared understandings, which enable them to jointly ask and answer relevant policy questions. And for example, by convening policy dialogues. And the integrated model, which contains a knowledge translation platform, brings together the before mentioned situations and embodies them. And with a platform, you have the chance to enable non-exclusive, transparent activities and information and contact at any given time, and also integrate more groups of stakeholders. I think it's worth knowing about the policy cycle. This is a very simple version of it. We have things like setting the agenda for policy actions, for legislation. It's the development of the policy, the implementation of the policy, and then the cycle continues with evaluation of the policy. And health challenges are given at a certain time, and we have the prioritization and policy options. The problem here is that we have a kind of mismatch between evidence given, data are available, and decision timelines, which are in general very short. So what we have to understand in knowledge translation is very much that information and action are linked to each other. And using a knowledge translation platform is very useful to provide information on any kind of results and methods and background and context. It enables feedback and contact directly to the persons who can answer your questions at the burden of disease teams, for example. And ideally, it gives information on timelines and updates and tells you when data will be available, or at least let people have an idea that you do have or provide regular updates. What I also would like to mention is this kind of parish framework. It's promoting action on research implementation in health services. It's again done or invented for health services, but what I like about this framework and why I mention it, it contains some core elements, and one is innovation, what is being implemented, recipients, individuals, teams, organizations are targeted, and context is part of the framework, like local, organizational, and system level factors, and facilitation, enabling and supporting individuals to change their practice and enabling implementation. And what I like about this framework is that it is user-centered. It takes a user-centered perspective and is influenced by innovation, recipients, and context. And I think that is something we should adapt for a knowledge translation framework or knowledge translation strategy in burden of disease. And one of the key things is to have an involvement of stakeholders. So who's a stakeholder? A stakeholder is any individual or group or organization who has an interest in your research projects or affects it or is affected by its outcomes. Stakeholders include those who are supportive as well as less supportive or critical of research. I think that's also important. And why should we involve stakeholders? For quality aims, like knowledge, like insights and data, for instrumental aims, like support and being known about, democratic aims, so everyone can participate. It's a lot about transparency of data. Where do they come from? How do we produce these data? Representativeness, and also things like empowerment of participants. Stakeholders do have large impact. They are mediators of knowledge for burden of disease studies. They can integrate or take us to further stakeholder groups. We can build a network with them. We can facilitate change in behavior, attitudes, and knowledge. They have an impact on acceptance of information, quality of health information, and also capacity building. So whether it is researchers, funders, policy actors, or brokers, integrated knowledge translation means a collaboration and building a network from start to finish. And I think this is easier said than done. When producing data as an institute, we start with data. We don't start with collaboration, but I think that is also key to build a network. So who is interested in burden of disease studies? I will present it on the next slide as well. There's very different groups from government to private sector, and one approach is to identify a variety of stakeholders, also to prioritize them, to determine who is important for you. Engagement through effective communication and also monitoring the effect of engagement. It takes quite a bit of time to do this identification, but I think it's really, really worth it because you will recognize there is a large variety in your stakeholders. It is researchers and experts within and between research disciplines. It's political decision makers, planners, managers in public health institutes and other fields of the other fields. It's local, regional, and national stakeholders. It's healthcare providers in formal and informal care systems. It's the general public, it's patient groups, it's interest groups, media, educators, NGO, the voluntary sector, and it's also the private sector, including insurance companies, venture capital, technical companies, manufacturers, distributors. So you will find a lot of stakeholders. And you can prioritize them with this power interest matrix and just think about how to communicate to them, or is there different needs from different stakeholders. When we think about tools, I think one of the keys, and most of the people who do burden of disease studies will agree, it is absolutely critical to do a data visualization, to have some kind of dashboard or app like our Shiny, or tools for processing information and for visualization like Power BI, whatever is used within your institute, for example. You can think about communication and dissemination tools as well, tools for online learning, survey tools, and also have contact or get in contact with tools for linking and exchanging information for all kind of social media. So I think there's also a big need to reach out to public relations or dissemination teams and IT teams. And when we talk about products, there's also a variety from simple to complex. It's reports and fact sheets that we can produce. We can produce short films, infographics, scientific publications. I don't want to deny them. They are very worth it, but it's just not the only product. Regular meetings and workshops that you are offering to your community, to your network, and newsletters, and also the presence at conferences and webinars, for example. So that's the last slide of the introduction. I bring it back here. And I think what I want to point out is that knowledge translations does not automatically mean impact, but also mainly engagement. And that is something that we have to keep in mind when planning a knowledge translation strategy or implementing knowledge translation. So that is the first part of the presentation, and I will switch to the other one. So what I did last year is I was able to facilitate a project in Australia. It is called the reception of health data. And I will present some methods and mainly results that I got out of this project. 1 second. So the background was that effective dissemination is crucial due to resource intensiveness. So that is kind of clear if you're producing a burden of disease study or working with burden of disease data. It needs a lot of resources, and you have to make sure, you want to make sure that people are using your data. So in Germany, the situation is that we started the burden of disease study in 2018. The piloting project was called Burden 2020. And after that, I think the final data have been published finally by 2022. And then we started to make the transitioning happening to have a continuous and permanent study and to update our data. And analyzing the Australian Institute of Health and Welfare's AIHW's well-established collaboration with stakeholders and their reception of health data at the national and regional level offers insights for improved knowledge translation, since the Australians are working for a very long time with burden of disease, and we knew it was very well established there. So that was kind of a very nice playground to do research on knowledge translation. And what I did was I went there for more or less 4 months last year, and I was able to do an online survey with AIHW. That was the quantitative part of the research, and the survey was implemented via the Swift digital online tool. That's an Australian tool that they are regularly using. It was 32 questions, and our goal was to have a maximum time of 15 minutes to answer these questions. And in parallel, I did interviews, that's the qualitative part, with stakeholders and experts from various Australian regions with a focus on Western Australia. I was using the app called Nota for recording the interviews and doing summaries or transcripting the interviews. That was very, very helpful. I loved this app. And I was analyzing it with NVivo 15 for a tool for qualitative analysis. So the scope of the project was how do users and stakeholders understand and use health data and especially burden of disease data? How can things be improved for the institute itself? That was in the interest of the institute to ask their stakeholders. And how does the AIHW communicate with stakeholders, and what can others learn from their approach, like the Robert Koch Institute or others? That was my biggest interest, of course. And the survey was finally answered by 54 people in during 6 weeks in April to May 2024. Actually, I was hoping for more answers, but I think it also reflects the reality, what is possible and what's not. So nevertheless, it gives quite interesting insights into what people need and how they use it. And in parallel, I was interviewing 18 persons in 16 interviews. People from the survey came from all over Australia. And that's what it looked like. That was a very proud moment when I saw the study is online and people can participate in the stakeholder survey. So the survey and interview topics have been aligned. It was about the use of BOD information, ratings of content and presentation, preferred burden of disease materials and trainings, future topics, frequency of information and level of detail that they would like to see, what is valuable for adding to the study, what's the work affiliation or job role and location of the people who work with these data, what's their preferred access to the Institute or the Australian Burden of Disease study, and what's their level of understanding burden of disease. So I will present now a few slides, like 10 slides, just with a lot of graphs. I was asking, how do users look after health data? Do they really just search somewhere, or do they access the page? And how often do they do that? And it really turns out people occasionally, or even most of them regularly, visit the website of the Public Health Institute, and they mainly also deliberately access the page. And 95% of the users stated that they used the Australian Burden of Disease study within the last 3 years and have been aware of the latest update, which was by then in, I think, December 23. What's their preferred engagement with the health authority? And most of the people said it was multiple answers possible via website or email, or also, and that is what the Institute does very nicely, webinars and virtual stakeholder meetings. Who are the people who use burden of disease data? That is all from the survey. Very interesting, and what we hope for, it's state government and politics and administration, and also mainly national government and administrations, but also academic research and NGOs or local politics sector, and a bit of education and others. Within the interviews, there was a variety of people from state government, politics, national government, academic research, and NGOs or patient organizations. Who are the people who use the data? What's their job role? People work mainly as research epidemiologists and data analysts. There was some policy offices, also people who have a high-level position like CEOs, some students, administration officers, for example, and 85% of the people stated they are expert or quite familiar with burden of disease. I know that this graph is not the perfect one for this kind of question, but how do people use burden of disease? What is their main field of interest or working area? Most of them, almost half of them, was working in preventive health, like working with risk factors, chronic conditions, beside mental health, and Aboriginal and Torres Strait Islander people. Whoever has spent some time in Australia maybe may have known about the government programs about closing the gap. So health of population subgroup is a very important topic within the public health landscape or public health fields. How do people use burden of disease and other health data? These are some examples from the survey. Also, multiple answers have been possible. So some people stated they use it mainly for background research or identifying health priorities, which is what made me very happy to see. I think that's why we produce these data. It contributed to government and health reports, to health policy, to academic papers, and was also used to inform senior managers, ministers, things like that. It contributed also to funding applications and provided information about the population and, for example, supported prevention and health promotion, among other things. Here are some examples from the interviews. I think I have a ton of material regarding the interviews, so it's just a small summary. People also stated it's used to inform politicians, evaluate policy during policy cycles, estimate the health impact, use especially risk factors for all kind of preventive measures in combination with health expenditure, and that was one of the main learnings that I had. It is absolutely common in Australia to combine burden of disease measures with health expenditure or economic burden of disease, do economic burden of disease studies. And maybe we can manage one day to start this as well. It was used to draw attention to specific diseases, especially by patient organization, advocacy, and lobbying for and within policy commissions. It was used for policy research and briefs and statements, used for planning of care services, for example, for hospitals or within the mental health field. It was used within strategic frameworks, health action plans or guidelines, programs like Closing the Gap for Aboriginal and Torres Strait Islander people, and also for own project or calculations, for health expenditure estimations, and for modeling. I have integrated this quote because I think it says a lot about the role of knowledge translation. And the person stated, if you haven't got good quality data, you can't convince the decision makers to do anything necessarily mind you, giving decision makers good quality data doesn't mean they act. It just gets you to the first base, but you have to have the data before you can achieve change. Also, if there's no data, most of us, I used to work for health ministers, and we used to say, if there's no data, there's no problem. So good quality data can show particularly where the disease is making a big impact, such as the burden of disease work, critical, absolutely critical. So I think it states that people are really using these data for facilitating a kind of change. What would people need regarding knowledge translation and materials? Users do fairly understand burden of disease, but they still need to disseminate this information. So it was stated that things like fact sheets and infographics are of value, but also, and that's why we ask this, half-day trainings preferred to one-day trainings. People, for example, during the interviews also stated, listen, we don't have many people here, we don't have much time, I cannot send them away all the time for 1, 2, 3 days for capacity building measures. Half a day training is even better. So short, compact form of training. There are a variety of reports that are presented by the Institute regarding burden of disease, and all of them have been used, like national estimates, risk factor estimates, or special reports on risk factor or subnational burden estimates. And what people stated is that it's quite important to link fields and burden of disease to other things within the website of the Institute, so that it is easy to navigate and makes you able to collect all relevant information. We also asked about the content of interest and the level of detail. So I had to get some knowledge about statistic area levels in Australia, which are a bit different. And I think what is very interesting, and we also asked about what would be helpful for information about subpopulations. It was mainly that, for example, it is helpful to combine burden of disease indicators with information that might affect the access to health information. What is stated here, it's a cultural and linguistically diverse people and English second language. And here we have the socioeconomic indexes that can be combined with burden of disease information with indicators. And I think that is something that we can keep in mind. And beside that, of course, people want information to the most disaggregated and smallest area level that is possible. Regarding content and frequency, that is something we have to answer for ourselves what is possible regarding capacity. But for example, there's a preference for yearly national updates. On subnational updates, it is not, in general not possible to do everything every year, but it is accepted and also good to do it every 2 years, for example, and also accepted to, for example, have a risk factor update every 3 years, all given the fact that you have the capacity. How do users look after health data? I think we can see here that the website, so a knowledge translation platform, is the main access point. There's also other ways that support this, even personal communication, informing academia, giving webinars, providing newsletters. And what regarding products, what people like to see or what they use in Australia is, of course, the reports. They are provided mainly as web reports. They like the data download, especially the people who want to do their own analysis. They like raw data as well. The data visualizations are very welcome, the dashboards, and also fact sheets and infographics next to other products. We were also asking about what would be good future topics and complements. people would love to see, I also got this information from interviews, is some kind of modeling or health intervention to see an impact. I will give an example later. Also small area estimations, geospatial mapping, summary data dashboards, interactive table builder products, so things that are more customizable for a user. And regarding social media, video formats have been mentioned. The Australians are doing this. They have a couple of videos on their website. There's interest in specific diseases like the aged and their burden of disease, the young and their burden, impacts short and long term from the pandemic was mentioned, risk factors like environmental or occupational risk factors, analysis of impact of commercial, cultural, digital determinants of health, compounding risk factors like syndemics when multiple determinants or diseases and risk factors coalesce. That is something we can transfer to the statistical departments and colleagues. Multimorbidity is a huge topic, and coexistence of non-physiologically connected conditions like cancer and mental health, and also specific topics like women's health, for example. What we can do is to regularly evaluate what we are offering. I had a look at the Australian website, and they're offering quite a lot regarding data, visualization, web reports, context, video content, fact sheets, and research projects. I think this information is quite new. So they give information what is possible regarding additional research, for example, from academia. And that can be complemented by workshops, trainings, online trainings on burden of disease, slide desks, and infographics. So these are the last slides for this part. The ideal situation for a user is to provide a detailed and complete data set available as raw data, a website that is neat, comprehensive, and easy to navigate, web reports with key facts and summary, well-structured, giving the main data, interactive visualizations with various graphs able to download, disaggregation of data by various area levels and population subgroups, customized data download, like the results tool of GBD, ideally customized reports with contexts. That is something I would like to work on. Visibility of time trends, a range of risk factors, data linked to health expenditure and economic burden of disease, very important and very welcomed by stakeholders and users. Interactive modeling and forecasting. I mentioned this before. For example, if you give users a chance to see if tobacco consumption, like a risk factor, is reduced by 5% within 3 years, how does this change or would change my outcome, my indicator, my DALI? Then a set of knowledge translation materials provided to users, trainings are offered, and to develop an embargo concept or implement updates and a calendar. I think I have to explain this. There's AIHW developed an embargo concept, means when they have updates on their data, like 14 or 10 days before, they inform the government, the ministers, the most important stakeholders about the updates so that they know what will be published. And then a few days before, a few days later, they also involve the media and people who will provide publications about the data, for example, and then at a certain point it is published to everyone and available. And they have this calendar function. They have this calendar in their website. So you can see for the next 3 months which reports will be published. And that is also very helpful for users to know there is an update in 2 months, so I can be prepared and the data will be available. What can researchers do to improve communication and stakeholder engagement? That is mainly from the interviews. like produce more than big reports and research papers. Within reports produced, having a lot of infographic with a bit of text around that is a quote, an executive summary, and providing key facts. Be regular with your formats, like doing regular stakeholder meetings, do media interviews, present yourself as an expert, be a trusted source of data and information, as the public health institutes are. Reach out to stakeholders or build collaborations with people who have access to stakeholders. Integrate policymakers into expert advisory groups. I think that is rarely done. Be aware of disease awareness days. That is something that the patient organizations use a lot, and it's extremely helpful where they use burden of disease data. And there are some take-home messages for us for improving knowledge translations, like provide a broad range of format, be available, allow people to reach out to you, be regular with trainings and meetings on updates, provide online materials for trainings and knowledge translation. Apply something like an embargo communication concept, so know who is your most valuable stakeholders and make sure they have the information ready. Integrate economic burden of disease and health expenditures and combine that with burden of disease data. Be complete as you can on indicators and risk factors, and allow modeling, forecasting, and trends. And if you apply all this, burden of disease data will be used. That is just an example from a local NGO, Injury Matters. And you see what they do with burden of disease data in Western Australia. And I do have a few slides from the burden of disease, German burden of disease study. Vanessa, do we have some more time?
Yeah, very quickly. Thank you.
Okay, I can do it in 5 minutes. So, as I mentioned, the burden of disease study in Germany is transitioning to become a continuous study. So we started with analyzing the data year 2017 with a complete overview on YLL, and regarding morbidity, we came out with around 20 diseases, and we provided information for federal states and 96 spatial. Oh, sorry, there's a spelling mistake. Planning regions, and we presented them on a separate website. And by the end of 2025, we will extend this range of diseases. We will integrate some prevalence data. We will produce time trends for 5 years, maybe more, and we will integrate our website and our information into the RKI Health reporting system on NCDs. We started with a basic visualization with 3 graphs like tree map and map, and a line graph for comparing diseases over age groups. And we developed new graphs over time, like this pyramid, for having an overview on YLL and YLD distribution over age groups. And what we also did was working intensively on to create a bivariate map with and combining DALI with the indicator on social deprivation in Germany. And next to providing a regional health monitoring, we are currently working on small area estimation by combining RKI survey data with secondary data and also administrative data, for example, from microcensus. So hopefully within the next months, we can present some more information about this experience to predict outcomes. Oh, sorry, there was also a mistake. And we will integrate the information on our website into the new health information system on NCDs. And by doing that, what we work on and what we hope is to integrate some kind of customized report, like having a visualization, put it in your shopping basket, and yeah, create a report out of it with some context information. That would be my dream, to do that. And I do have some more quotes, but I think we will skip them. And so big thank, or cheers, as the Australians say, to the Institute of Health and Welfare. It was Michelle Gourley and her lovely Burden of Disease team and Richard Jukes, who was our initial contact and was also part, for example, of the Burden of Disease Network. The Department of Health in Western Australia, it was Laura Kirkland and Anne-Marie Chaplin and their team, and our Burden of Disease team at RKI. So.
Thank you very much, Aline. Yeah, indeed, really good work, and yeah, it seems like stakeholders demand a lot from us. So I guess there is also like a problem of resources there, and like meeting resources with expectations. But we can continue with some case examples from two other Belgian burden of disease studies that are quite already running for a few years in Europe. So maybe I can ask my colleague Aline to present what we have done in terms of stakeholder engagement in the Belgian burden of disease study. Thank you.
Yes, thanks, Vanessa. Do you see the right screen?
No, we see the other one.
Yep. Sorry. Getting there. Yes, now it's okay?
Yes, perfect, thank you.
Okay, well, thanks very much, Aline, for introducing knowledge translation so nicely, because I think it's nice to see also that a lot of things I will present check some of the boxes you have mentioned of what users need and what we can do. So I'm very happy to see that. So we'll share with you some of the experience we have in the context of the Belgian National Burden of Disease study. So as Aline already showed, our goal is to climb these health information pyramids. And we do this in Belgium. So we have data that we use to compute prevalence, DALY, YLL, YLDs. And we frame this then into a reporting that is done on our health status report on Healthy Belgium website. But our goal is really to go from this health reporting to the knowledge translation. And three key aspects I like to think about when thinking about going from health reporting to knowledge translation. It's first adapting our content, adapting our messages, adapting the way we are framing this. So it's looking at the message, the way you're going to phrase it, but also the diversity of audience. So Aline mentioned the different key actors that you have to identify. And so you will adapt your message to this different audience, but also the medium that you're going to use to reach this different audience. But that's something very important to start thinking with. Second, it's to build the process. And by process, I mean a lot of the interaction. So the interaction goes both ways. It's not just us commenting to them. It's also them communicating with us. So we want to keep this communication going and flowing at different moments into the process to really make this happen. And the last part is really to disseminate all this diversity of projects we have built. And this is what we are going to see today. So as Aline mentioned, a key aspect is to have a nice website where you can share your results. So for us, this website is called Healthy Belgium, and it's a platform where we try to gather in Belgium with different institutions key information about health. And within this platform, we have different topics. One of them is health status, where we try to summarize key information about health status in Belgium. And a part of this, a section of this website is about burden of disease. So important to also mention that this is updated continuously. So every time we have new data, we introduce it on the website. And so for burden of disease, we have a yearly update on the estimates. This website is also available in 3 languages in Belgium to facilitate also communication with different groups in Belgium, but also internationally because the website is available in English. So what can you find on our website in this section about the goal of this section is not for scientists with a big understanding of burden of disease, but it's really to communicate more clearly. So we have different pages on different topics. So we have a page on DALI, a page on YLL, on YLD, a page for each of the risk factor that we currently have in our study, and a page with projection. We have also a separate chapter with the cost of illness, because now Aline mentioned that this was an important part, but the other section on the same website. And so what can you find on this page about that topic? So you're not going to find all the estimates available that we understand and to extract from this the complete data set. So here the page on DALI, we have on the top of the page the main key messages that about the difference, the total number of DALI, specific disease and specific subgroup that are of interest. And we try so to summarize this key insight. We do this thanks to graphs and to interpretation of graphs. So we try to use a combination of these visual graphs, but also giving some text, some key interpretation on how people should understand this graph. And we try to do this in an accessible language and a way for non-scientific person to be able to understand it. So some of the technique we use for this, for example, is to give meaningful titles to section. So because we know that people are not going to read through all the text, so we want to give them key message that pop-ups from the pages, so using meaningful title. As Aline mentioned, the concept of burnout disease are quite difficult to understand for most people. So we try to have definition on the terms that would be more complex. For example, here you click on DALI, you have a definition of what is a DALI, but also other concepts like age standardization are explained a bit more clearly on the website to support people into understanding better the estimates. We also use interactive graphs. So you can see here, I clicked on the and people can play with the graphs, make some diseases disappear to just select a few that are of interest to them. And people can download the data that are beyond the graph and also download in other publications, in other so with this website, we also want to facilitate the access to the further information for those who are interested in more details. And so at the end of the page, people can access the methodology that we use for creating this estimation, but also some background information and some more information on the topic. As Aline mentioned, it's important to have these summaries with the key insight, but it's important also to have interactive application for where the full data set is available. And we have this through Shiny apps. So we have different Shiny apps for the different topic that are available. And on those Shiny apps, we have different kind of visualization, and people can select parameters to modify this visualization. So they can look into DALI, YLL, YLD. They can use it as a number or as a rate. They can look at different stratification by region, by sex, by age. And they can select also, they can select the, make their own data sets to download. So all the data is done, it's to download, and the graphs are also to download and interactive as on the website. So it's a nice tool for people who want to go further, want to make their own analysis based on the data, or that needs specific region data only for a specific region or a specific age group. They can do this through this Shiny app. So we have the complementary products here of the website that present the key information to explain for people who don't know so much about it, and then we have these Shiny apps where for people who want to go further and need more information. So this is two big outputs we have, but as mentioned, the challenge is to now disseminate these outputs and make sure that this project can be used and are known and can be used by people who need them, by stakeholders. So we have different ways of disseminating these projects. One way is through a newsletter. So every trimester, we send a newsletter to people that are subscribed, and we let them know about the new updates and the new results and the new key information we think that are important for them to know. But this dissemination way is restricted then to people who already know the website, already know the burn-of disease study, and are already aware. But that's a way of keeping them engaged and keeping them aware of what is going on. But we also want to extend the number of people that are involved in this. One way of doing this is through social media posts. So we use, as Aline mentioned, special days. So for example, a few weeks ago was World Asthma Day. So we made a publication on our LinkedIn about this. And we mentioned the number of healthy life years lost due to asthma in Belgium in the publication, but we didn't make it the big title because, you know, people who don't know burn-of disease, they will not be attracted to this. So we have a publication here that bring other messages, but mention also the years of life lost. And if people click on the link for more information, they will end up on the website of our burn-of disease study, where they can learn more also about burn-of disease. So this is a way that we use to gain new users, but it's also restricted to people who follow already our institute, Scienzano, on social media, or follow people who follow people that follow Scienzano, and we'll see people re-sharing our publication. So it's not yet, it's people interested, but it's not yet everybody. But that's a good way also of keeping the momentum, keeping the information going. Another way we do communicate with people is through press release. So we work, as Aline mentioned, with some kind of embargo concepts, where a few days before a press release, the press release is sent to our Minister of Health, National Minister of Health. And also a few days before the release, we work with known and trusted journalists from popular media in Belgium, and give them access to some of the results and help them draft a news article that will have the premiere to release on the day of the release. So, but next to that, then the press release is communicated to every newspaper. We get interviews, we go on the radio, we TV sometimes, and participate into these different paper. So that's a really nice way to gain new users that are more than people already interested in this topic, that is more general, also public. And here also challenge is to phrase the message in a way that will interest these more general people that are not the same than people who are experts in burn-of disease already. And the last way we are disseminating these products is through many presentations in different contexts and settings. That would be academia, but also federal or regional organization, also field organization, NGOs that have a specific interest in some specific disease sometimes. So this is a very broad activity, but very nice and rewarding because you can get to meet people, you get a feedback from them and a reaction from them in real life. Another way we've getting this reaction in real life, and this is one of the last things I want to mention, is our yearly stakeholder meeting. So once a year, we invite more than 100 people from all kind of organization in the whole of Belgium to come to our office and to discuss this. So first, we update them on the new key results, but the main part of the meeting is for us to ask them for feedback and for the progress. So we try to do this in different ways. We use different tools. So sometimes we ask them to give us some suggestion, and then everybody in the room can vote on this suggestion to see which ones are most important for them. Sometimes to ask them specific question with specific answer, and we ask them to rank this answer based on their priorities, or to give us any other feedback that can be useful for us. And these feedback and priorities that we get from this meeting, it will be the basis for action plan for the coming year. So we really use this to guide also our priorities and the changes we want to make into our outputs. And new that we are implementing now is what we have named the Health Information Academy. So in the context of this stakeholder meeting this year, we will have a workshop in smaller groups of stakeholders where we're gonna work with them through these outputs and teach them how to use them how to use them better, what they can find there, and using, for example, questions to tell them, okay, if you have to answer this question, how can you do this with what is available? And we show them and teach them how they can do this. So we try to have a more proactive also teaching experience and training about how they can use this and how this might be more interesting for them that they already know. So we're very exciting for this new workshop, this new activity, and we will let you know maybe at another stage how this went. But yeah, that was some of the things we do in Belgium. And I welcome any question in the chat if you have. Thanks a lot for your attention.
Thank you, Aline. And yeah, we do a lot of efforts to engage with stakeholders, and this a bit brings back with to the message that Aline had at the beginning, that impact doesn't always translate, or engagement doesn't always translate with impact. And we see a lot that even if we put a lot of efforts, sometimes it's really difficult to see some impact. But yeah, this is also the game. I'll give the floor to Henk, and indeed you can put your questions in the chat. We will answer them after the presentation of Henk. So Henk, the floor is yours.
Thank you, Vanessa, and thank you for inviting me. Let me get my presentation up. I think you see it now.
Yes, perfect, thank you.
I will give you a brief presentation about the experience actually that we have in the Netherlands about the National Burden of Disease study in the Netherlands that we call the Dutch DELIS. We do that National Burden of Disease study at RIVM, the National Institute for Public Health and the Environment, already since 1997. So we're doing that for quite some years. And we have the most recent update published actually last year, so for the year 2022. And we updated the methodology, we updated a lot of data. And we have the privilege that it's also part of the Dutch Public Health Foresight study that we do every 4 years. That has a legal basis, so it gets a lot of attention in the Netherlands, and then we can also use it as a platform to publish and present burden of disease as well. And something rather unique for that is that we also do projections for that. So we have projections of burden of disease indicators up to 2050. And knowledge translation, if I state it very more popular, it's getting the right information at the right person at the right moment. So what, who, and when. And actually, we do that. The Public Health Foresight study is commissioned by the Ministry of Health. So policymakers are, let's say, our main audience, our main target group that we try to reach out to. So then, of course, burden of disease is rather important. We cover now more or less 120 diseases or groups of diseases. And of course, the link to the risk factors. We use the population attributable fraction for that, and we have more than 100 risk categories right now. And Aline showed this already. The first Aline showed this. This is about the when, the health policy cycle. This is a simplified version, and of course, if you have burden of disease calculations, then it can be used for priority setting. And that is defining the agenda for policymakers, not only the disease burden, many other things as well. However, we also want to see what can we do about it. And then, of course, and then we're talking about policy strategies. And then we want to link the disease burden as well to risk factors that might be more of interest for policymakers. This is something that we did some years ago. This is, let's say, the infographics that we're trying to use to make it more attractive for people to have a quick look at what the outcomes are of the Dutch DALIs. And it's easy to see what actually the communication of such an infographic is rather important. That's something you might not realize at the beginning when you're making it, but very often it communicates very strongly, for instance, that cancer is very strong, or very big actually. Cardiovascular diseases are the second one. But for example, infectious diseases are hardly visible. So those get hardly any attention for this. We also do the what I said before, the future disease burden. And then we have the whole trajectory from 2020 to 2050, and then we use a slope graph to indicate what are the major changes. And one of the things that is communicated by this graph is directly that how important dementia is becoming in the future. Also important, what you can see, that mood disorders, they are ranked in the first place, will be passed by dementia, but stay at a very high level also in the future. This is different, I have to say, from the results that we had before. And that is also due to an update of the disability weights that we did for the Netherlands, also for the study published last year. And in the new disability weight, actually the mental conditions were ranked much higher than, let's say, the more traditional cardiovascular and cancer burdens. That's also some part of the game, that sometimes the data changes or methodology changes, and then the outcomes are also different. Then something very popular within the public health foresight studies, actually, if we link it, the disease burden to the determinants, the risk factors, and then we try to make a nice infographic out of it. I have here displayed 3 of the outcomes, 2014, 2018, and 24. This is a graph that always gets a lot of attention. People are focusing on that, and then they're comparing different percentages being presented here. And of course, you get a lot of questions why things changed. And what I said before, it can be because of methodology, it can be because of data, but also what we did with the disability weights. So if I have a quick overview of the knowledge translation in practice, actually, and that's something that I was very glad that Aline also stressed, that what we in the Netherlands also find rather important, not to only think about the users, but also about the people providing the data, and improving actually the quality of the input data for doing the burden of disease studies or the calculations. The nice long quote that you showed at the end actually is very important. The quality of your data also is rather determining for how the quality of the outcomes are. And we try to have an intensive involvement of all our data and information partners for all aspects that have to deal with the calculations of the burden of disease. That's on the input side. On the use side, then we also try to improve that as well. What I mentioned before, the public health foresight study, of course, that includes the results, but it also has an interpretation of the results, a description of the context in which it's happening. So in such a way, you have a much, let's say, a nice contextual description of burden of disease, not that it's separate considered, which is rather difficult sometimes. Also, we developed a dashboard with all the results on our website, facetinfo.nl. That's mostly in Dutch. We have a methodological background reports that we do for all the choices that we have made within the calculation of the burden of disease. But rather important, actually, I would say, we have various sessions with policymakers and other stakeholders about the results. And very often it is triggered about differences in percentages of the determinants attributable of the disease burden attributable to the risk factors. Or like with the diabetes fund, we had a very interesting discussion about how the disease burden linked to diabetes is changing over time, or actually not increasing what they were expecting. So we have very interesting sessions, also rather important to know a little bit more about the input data that we use and what is behind that. And it's being used, and that's something very interesting that, for example, the health mission of the Dutch government includes burden of disease as one of the goals that they stated for 2040. So what are the lessons learned of those decades that we are doing now, the burden of disease study in the Netherlands? Still, the interpretation and the use of the DALYs is difficult. It is the unit. Years lost is a very difficult one. There are a lot of choices behind it. A lot of data is changing over time. So it's not easy to have a good interpretation of the results. That's something that we have to deal with all of us, but I think that's still rather a big obstacle of it being used in the proper way. Secondly, I mentioned it already, the methodology updates are sometimes rather difficult to communicate. The disability weights I mentioned, that percentage of burden attributable to risk factors, yes, it is changing over time, and people are then comparing also results from the past with the present, which are, we all the time say you cannot do that, but people are doing that. So we have to have a more active role in how to deal with that. And then the link to risk factors is very essential for the policymakers. However, it only says something about the theoretical avoidable burden. So to really make the step towards policymakers and something that they can use, it is also that we have to have a stronger link to interventions, all kind of policy interventions. The potential impact fraction might be very important there to say something about what is actually the avoidable disease burden and what kind of policy interventions then are needed to avoid that disease burden. That is something that we're investing in right now, and I think that is rather crucial also to have a burden of disease being used much more by policymakers. Thank you.
Thank you very much, Henk. And indeed, your last point about health impact assessment, like monitoring interventions, it requires even more maybe the engagement of stakeholders, because you would want to have a more one-to-one or like a everyday conversation with them on which are the interventions that maybe are useful for them, and so it's even more important in that context. But thank you all for the presentations. So we have a few minutes for questions. So in this format, you are not allowed, let's say, to unmute yourself as a participant, but you can write your questions in the chat, and we will take them as they come. I already see a very long question from Eleonora. So she has a general question inspired by Aline's presentation about maybe the burden of disease network. She's asking, did you look or are aware of studies that look at differences among the different public health authorities in how they disseminate burden of disease results and which kind of topics they cover? So more like looking into, comparing burden of disease studies. I guess this was for Aline, Anton.
Okay, thanks for the questions. Not an easy one. So I was working, or I started working with National Public Health Institute, the AIHW, and then I also went to Western Australia to the Department of Health, and they also have an own burden of disease team. They mainly they work together with the Public Health Institute, and they analyze data for Western Australia and also provide information, especially to their own stakeholders. They also have their own stakeholder network, and of course they have different duties, but it is in a way also comparable how they do this. I'm not sure what's the exact question, but maybe if there's someone from the Australian Health Institutes, they can maybe also answer this question. But I don't know, they're not allowed to unmute, right?
Yeah, well, I think, yeah, I don't know if there has been such a study comparing, because Eleonora was bringing the point that for her it would be interesting to check how. Sorry? Brecht, your connection is cutting. We cannot hear you. So.
The question also.
Yes, please.
Brecht? Brecht, can you hear us? Yeah, so she was thinking also that maybe different like topics could be handled differently in different burden of disease studies in terms of communication, so that it would be interesting to compare how this topic are handled in different burden of disease studies.
I don't have much information, but of course they are doing, they have certain topics they focus on, for example, environmental burden of disease. I know that there's research ongoing how to present it, because that is extremely interesting on a smaller area level. Maybe that is part of the question. And of course you have different topics that you want to report and that are interesting for your stakeholders. But
Yeah.
it's still a close collaboration regarding data and methodology.
Yeah, thank you. Eleonora, feel free to put some other questions in the chat if you would want to clarify more qualification. So there is also a grant that asks a question about how much attention is being paid to the disability weight factor, which could vary a lot by country. Maybe Henk has some ideas.
Yes.
Also, the Netherlands has their own ones.
Yes, I think there is a variation of disability weights over time, but what we saw that mental diseases are now valued higher regarding loss of quality of life than other diseases. And I think there's also variation among countries. We saw that with the European disability weight study that Jonita Haagsma did with 4 countries in Europe, that there were some differences as well. But I think it all contributes to, let's say, uncertainty that was not mentioned yet. Something that we also are still struggling with, how to deal with communicating uncertainty. Of course, with all disease of a burden of disease calculation, uncertainty plays a role. However, we're not very capable of communicating that uncertainty in a proper way. And it's going beyond statistical uncertainty, I have to say. It also applies to all kind of structural aspects like disability weights, like prevalence data that are of good quality and some of lower quality. We're not yet there to communicate that in a proper way. So that is still something that we have to handle, and that includes the disability weights as well.
Yeah. But indeed, uncertainty is a bit of a tricky topic, because also us and stakeholders perceive uncertainty or have a different definition of uncertainty. So yeah, it's a bit difficult to communicate. So there is a comment from Zubair. So he says that he still finds it difficult to educate Irish policymakers even after our knowledge translation workshop that we had in Cork 2 years ago, and so he's asking about any additional thoughts or like some ideas about how to educate them in an easier way, I guess.
Maybe I can respond quickly, because I I was there at the workshop, and I can tell you the situation in the Netherlands. We are doing the burden of disease studies already since 1997. However, since only the last editions, policymakers are really embracing the concept as well. So Yes, it takes a long time, and I'm afraid not only one workshop, and it was a very nice workshop in Cork that we had, but not only one workshop. It really takes a long time for them to embrace the concept of burden of disease, and also how they can use it. So keep on going, I would say.
Yeah, indeed, that's good advice. Are there any more questions for the speakers today? I have a bit of a more fundamental question just because every time we talk about knowledge translation and all the activities, like press, social media, workshop, I'm always wondering if it's actually the researchers are the ones that are supposed to have this role of mediators with stakeholders, or if actually we should think about like another type of profile, maybe less scientific. I don't know if you have any thought of this, or for example, for the Australian burden of disease, if they have somebody that is appointed to communication that has not a very scientific profile, but more like a communication profile. Yeah, please go ahead, Aline.
So what I experienced from the AIHW is that they have a very strong and engaged communication department, and they have, I think they are a huge support of the burden of disease updates all the time and do regular stakeholder surveys and things like that, and apply this embargo concept. So it's not everything on the researcher side. It's a close collaboration, and to have that, and for example, at Archive we have a very good social media team. So I think you have to search for partners within your institute and within your working environment also. But there's more and more networks coming up for public health, in the public health field for certain topics. And I think they can also help supporting and spreading the knowledge on burden of disease.
Yeah, indeed. Thank you. And in the other burden of disease studies, so I know that in Belgium we have a support from communication department, but I think us scientists, we do a lot of the work behind. But I don't know, Henk, what is in the Dutch case? Do you also have a team dedicated to this? You're muted, yeah.
I think that's a very valid question. Very often the people doing the burden of disease studies and calculations are also the people involved in communicating the concept, the results. And yes, it would be better to have really communication experts. And we do have a communication department at RIVM. However, they also find it very difficult what burden of disease is. So, for example, if we're writing a report, we always have to write a summary that is very simple, very well understandable for the general public. However, then explaining burden of disease is always a struggle to do that in a more, let's say, simple way that the general public really directly understands what it is all about. So yeah, it is, but I do think, like Aline, Anton, being devoted to more or less knowledge translation, I think that is the proper way to go. But yeah, you need the resources for that as well.
I would maybe add in the Belgium case that a struggle to translate the concept of burden of disease into national language. So Dutch is right, okay, but French is a more challenging. And so there is maybe not also a good way of translating this concept to other languages that are, and it makes it even more difficult for people to grasp this concept sometimes.
Yeah, le fardeau de la maladie.
Yeah, le fardeau de la maladie. Yeah.
Okay. Thank you very much. I don't see any more questions in the chat. So maybe I suggest we thank our speakers today for the very interesting, and maybe you were inspired on some activities for your burden of disease studies or any other type of communication of science. So yeah, you can be updated on future webinars on our website. And thank you everybody for joining.
Thank you.
Thank
Bye.
you. Bye-bye.
Thanks a lot. Bye-bye.